not really sure if being the last speaker is the best. Sometimes we all get that carbohydrate after lunch, so hopefully I can keep you awake and alert and ready to go. The first thing I always like to do when I start a presentation is thank the caregivers and the individuals with dementia that I have worked with over the last 30 years. You will hear stories today, you will hear techniques that I have used. They have taught me everything I know, and I would not be who I am if it was not for them. I always start my presentations with this slide right here. Very basic, right? Dementia is an umbrella term. I probably speak 10 to 15 times a year at different conferences. In those conferences, I typically have someone raise their hand and say, what's the difference between Alzheimer's and dementia? I think people are getting a little smarter on this question, but I still get it quite a bit. So I do like to just explain dementia is an umbrella term. It is not a disease process. It's a group of symptoms that tells us something neurocognitive is happening. If I have Alzheimer's, I have a type of dementia, but if I have dementia, I can have lots of different types of Alzheimer's disease. So one of the easiest, right? This is one of my favorite slides to show, because when I say to people, I'm a dementia specialist, they say, oh, your clients have memory loss. I say, well, it's a piece of it. It's not all of it. I say, this is our master computer, this wonderful brain up here of ours, right? But each part has a different function. Now, you may look at this and go, Patty, there's some words up there that are spelled wrong. This slide comes from the UK, so some of the words are spelled a little bit differently. But when we talk about personal care, and we're talking about planning, we're talking about sequencing, we're talking about that frontal lobe. And when that frontal lobe's not working, planning, sequencing is more difficult. When we are talking about getting in and out of a tub, visually, how am I seeing that? My occipital lobe is affected. I can't do it as well as I used to. Motor cortex, how I move, how do my arms move, how do my legs move? My temporal lobe, there's that memory, but also there's understanding language. Occipital lobe, my vision is impaired with this disease. So I always say, one of my phrases I say all the time is, dementia does not take away intelligence. It takes away function. Because I may be a person with dementia, and I know I have always tied my shoes, I should be able to tie my shoes, I'm gonna go tie my shoes, and then when I try to do it, my brain fails. It fails me. So now I might get angry. I might get frustrated, and we're trying to figure out how do I get them through this. And here's one of the things. If you learn to listen for clues as how I feel instead of what I say, you'll be able to understand me much better. This is from a woman, her name is Maria Batonis. She's written a book, When Caring Takes Courage. I've seen Maria speak a number of different times, and this really stayed with me. We know that one part of the brain that's very active in all of our lives is the amygdala. And Stephanie talked about it in the last group. She talked about how emotions, feelings, fear are a big part of this disease. So dementia starts on the outside and works its way in. The amygdala is up and in the brain. The unfortunate thing is these lobes on the outside misfeed that part of the brain, give it bad information. But you may learn that someone's fuse is a little bit shorter than it used to be. They're quicker to react instead of respond. All that emotion. I can't get into giving care until we talk about some creative communication and some helpful tips. Always begin by being friendly and state your name. We know one of the first areas of the brain that's affected, especially by Alzheimer's, is that temporal lobe, and that's language, expressive and receptive language. What I'm hearing and what I'm receiving and what I'm understanding. The first part of language that's hit by this disease are nouns, naming things. So I may look at my child and be like, I know that's my kid. I know I should know her name, but it's not coming to me because there's a block there, and that part of the brain is not working the way it should. So anytime I walk into a room, anytime I am approaching someone I know has memory loss, good morning or good afternoon, it's Patty O'Brien. It's great to see you. And then I stop. You're going to hear me say a lot today. Pause, break, take a breath before you move on. Our world goes much too fast. for folks with dementia. Inform them of every step and every action. We go from A to Z, right? We say, oh, it's time for your shower. And I'm the person like, shower, holy crap. What about processing? What about sequencing? What about all these steps? How many steps are there to take a shower? There's a lot. So when I'm working with someone with dementia, I want to go from A to B. What's the first thing I want them to do? Might be that I just want them to stand up. So that's the first thing I'm going to ask them to do. This is a yes getting to another yes, instead of hearing no right away and shutting me down. I want to go yes to another yes, and then keep going with my yeses. Because once I get a no, there's my brick wall that I either have to break down or stop. Break down those tasks, speak in a normal voice, even if they're hard of hearing. Because as we speak louder, it starts vibrating off of them. And it might not be that they are listening to the words, they're just feeling that beat off of their chest, or they think, wow, she seems mad. I must have done something wrong. There's that emotion again. Include the person with dementia. Are there any doctors in the room? Okay. So the doctors are the worst at this. That's why I asked the question. I take lots of folks to the doctors, and we sit down, and what is the first thing the doctor says? How are they doing? And I'll say, I don't know, how are you doing? And usually before I walk into a doctor's office, I will say to my client, we're going into the doctor, they're going to ask lots of questions. They're probably going to ask me some questions. How do you want me to handle it? I would say 99% of the time, my client says to me, oh, you take it. It's all you. And then halfway through the conversation, I'll say to my client, anything you want to add? How are you feeling about this conversation right now? But it's important that we do that. Their body language will inform you of their mood. Learn to read it. And then as the disease progresses, and this line right here, I want you to read it and read it and read it. As this disease progresses, words no longer their friends. As this disease progresses, the words that we use become their enemies because of processing and understanding. We have to find a different way to get our point across. And then in late-stage dementia, individuals really interpret their world through their eyes, not their language. What they see, what they touch, it's perceptual. So people with dementia can't change the way it makes them act anymore than a cancer patient can keep the cancer cells from spreading. They do not have control. So I'm a recreation therapist. That's what I have my bachelor's degree in. I went home from college one day. I said, Dad, I'm getting a degree in recreation. He said, you can have a degree in that? I said, yes, I can. Yes, I can, and I will. And I was a rec therapist for many years. But this is the reason I want this slide up here. Not because I'm a rec therapist, but because when I talk to people in the community and I say to them activities, they think recreational. Right? They think bingo, they think arts and crafts, they think going out to dinner, recreational. I want you to change that. Activities are things we do, like getting dressed, doing tasks, playing cards, paying bills. They can be active or passive, done alone or with others. So activities are anything you do in your daily. Hello is an activity. If you don't have 2 to 3 seconds to stop and say hello, keep walking. If I'm at Stop and Shop and I see my friend Michelle Wyman, who I work with, I'll probably just go, hey, Michelle, good to see you, and I keep walking. She's like, hey, what's up? If I know Michelle has dementia, and I just walk past her, and I go, hey, Michelle, good to see you, and I keep walking, by the time she processes that, by the time she realizes that, I'm gone. And I've just made a confused person more confused. So again, if you don't have the 2 to 3 seconds to stop, make a connection, keep walking. And they might yell at you, like, where are you going? What are you doing? But you have to make that connection before we go to the next step. Boy, getting someone to say yes. We hear no a lot. Again, I was the recreation therapist. I was the fun lady. I was going to take you to music. I was going to take you to a party. I was going to take you to bingo. I was fun. I'd walk in and go, would you? They go, no. What do you mean, no? We don't even know what we're going to do. The person with dementia a lot of times says no because maybe you'll go away. Maybe I don't have to think about it. Maybe I don't have to process it, and then I don't have to do it. I can shut it down. So if you don't want to hear the word no, don't ask a question that's a yes or no question. So first is our approach, right? We walk in, good afternoon, it's Patty O'Brien. Good to see you. And then we stop. And a lot of times my clients will echo back at me, hi Patty, good to see you. Then we connect. Now, I'm 5'9", I'm a big woman, I have these shoulders, I know that. I used to work in Rocky Hill, Connecticut. The majority of my residents were 4'11", 5 foot, because they were all Italian. They probably weighed about 100 pounds, and oh my God, here comes Patty O'Brien. I had to be very aware where my body was in their space. And I still have to do that, because I'm a big woman. Because if I stand right over you, and you're sitting, how are you feeling? Whoa. Right? Or if I get too close, back it up. So how do I connect? I have to give them that space, and then I'm going to use a statement versus a question. Instead of, would you, it's time for lunch. I have a seat for you. Come with me. It's amazing sometimes as they hear the words and they start to get up, come with me. Okay. And then if you want them to do a task, mirroring a task. So I'll tell you one of my pet peeves in life in nursing homes and assisted livings. If I'm in an assisted living or a nursing home and I see a staff standing next to a resident with dementia right over their shoulder while they're eating lunch and they're getting mad because they don't understand why they're not eating, I say to the staff, if you were in a restaurant and your waitress stood right there while you were eating your dinner, what would you do? They're like, I tell them to go away. I go, exactly. So why is it normal, or why is it typical for that person as they sit there for you to be standing right here, waiting? Back it up. Give them space. Planning a day can help a person with dementia. They need to spend time doing different activities, provide meaning, enjoyment. A lot of times, too, you want to set up, it's almost like I know the next thing I'm going to do. So that's muscle memory, and that's repetitive, repetitive, repetitive. And it's hard, right? Because are you guys all rec therapists? Are you all on duty? You're on duty 24/7, but you need a break. You know, people will say to me all the time, I don't know how you work in facilities. I haven't worked in a facility in a while, but I don't know how you do it. I said, you know what? After 8, 9 hours, I go home. I go home to a husband. Sometimes he had dinner made for me. I go home to a husband that would take me out. I wasn't there 24/7. It's a little bit easier for me. Or a lot easier, I should say. 5 senses. To help focus on a conversation, because we go back to that line, words become their enemies, we're going to give them something to see, use something to hear, hand them something to touch, taste, or smell. This was so apparent to me as I did a program on the spring birds one year. And I talked about the blue jay, and I talked about the cardinal, and I talked about the robin, and I just used my words. And my residents were like this. And I was like, okay, that did not go well. So I went down and I went to the Audubon Society and I bought a blue jay and I bought a cardinal and I bought that robin redbreast. And I brought out the robin and I said, here's the robin redbreast. And the woman goes, springtime. Spring? I go, you bet. We think of spring, right, when we see that robin. Yeah, and it pulls out the fat, juicy things. I said, the worms? She goes, yeah, those worms. Then I brought out the blue jay and one of the guys goes, that's the mean one. I said, well, he does get kind of a bad rap. And he goes, but he's on the tube, kicking them off, kicking the little guys off, the little ones. I go, well, yeah, on the feeder. Yeah, the feeder. And he goes, yeah, the little ones. I go, you mean like the finch or the house sparrow? Yeah, those. Then I brought out the cardinal, and I squished it, and it sang its beautiful song. And excuse my language, but I will use the language he used. That son of a bitch used to wake me up every morning. Never heard the word cardinal, never heard the word blue jay. What else? Robin redbreast. What I heard was description. Couldn't come up with that last word. That's what they're missing in their language very early in this disease. So anytime we can use senses, and the reason I tell you this is because now we're going to talk about care. So how can we incorporate other things into the care that help with the 5 senses? So keep in mind, as memory loss continues, functional abilities of the person will change. So it is important to know. Sometimes the person with dementia may say something mean or hurtful. We certainly heard this. If you were here in the last group, Stephanie talked a great deal about this. It is very hard sometimes when people say things that are very hurtful. Know that it is the disease process. So I will tell you about my Sylvia, who I loved dearly. She lived in one of my facilities. She would sit at the end of a hallway, and if I was walking down the hallway once a day, 100 times a day, I would hear this. And I thought, here it comes. She'd go, "You are really fat." I'm like, "I know, Sil, I'm a big woman, but you must have been fat your whole life, because you sure are graceful." I said, "Thanks, Sil. I'll see you later." Well, one day her daughter was there, and I loved Sylvia. She's one of my favorite ladies. I was walking down the hall, and I heard, I thought, here it comes. And she said it again, "Ugh, you are really fat." And the daughter was like, "Mom, why would you say that? You love Patty." And she's like, "Well, look at her. What do you want me to say?" This is the reason I tell you this story. When your loved one's having a behavior like that, you're not going to change it. Right? We try so hard, like, that's not appropriate. Why would you say that? You love Patty. You go to music with her. Sylvia and I did a lot of singing together. I learned a lot of old Jewish songs with her. You can probably tell by my name I'm not Jewish, Patty O'Brien, but with Sylvia, I learned them. So I had a great relationship with her. That was just how she interpreted me when she would see me. So why does someone with dementia need help with personal care? Even though the person may physically appear capable of dressing and provide their own activities of daily living, changes in the person's brain may make it hard, right? So lack of insight into the need, right? Of course I took a shower. I've always taken a shower. What do you mean? I don't need any of your help. May think they already did their personal care, especially if we don't show up till like 10 in the morning and they've been up for a couple hours. I'm already dressed. Of course I already did my personal care. Motor planning challenges. Right? How does my arm go through that? How does my leg go through that? Lack of initiation or motivation. This is something a lot of people don't talk about. The part of our brain that tells us get up, get going, get moving is broken. It's not telling us to do that. So a lot of times we'll start an activity with someone and it clicks. Right? You're like, oh, that just clicked. They're now doing it. That's why we mirror tasks a lot. We have them watch us do something because we're helping that brain click. So bathing is often the most difficult personal care activity that caregivers face. This is what I hear from my families all the time. It's a very intimate experience. People with dementia may perceive it as unpleasant or intrusive. So everybody know who Oprah Winfrey is, right? Right, I'm going to move Oprah Winfrey into my community, and she has dementia. We're now it's time for her shower, and I send a male down to her room to give her her shower. What's going to happen? Why? Oprah was sexually abused by an uncle for 7 to 10 years as a child. I can't imagine the fear, the trauma, and that amygdala not holding on to that absolutely horrific memory, because that's what that amygdala does sometimes, holds on to the best and the worst. So we need to know the background of your loved one. Have they been sexually abused? Do families always know that? No. But if you do know that, please have that conversation, whoever's taking care of your loved one. We need to know those things. It's important. The other thing about bathing, so if anyone's a nurse in the room, many of us were taught to start at the head and go down, right? We start washing up, so the soap will wash over the body. In dementia care, start at the feet and go up. Think of it this way. If you have a bee by your foot, you're kind of like, oh, that's annoying. If a bee is here, what are we doing? This is a very intimate place on our body. I also, and Stephanie, said it earlier, our nerve endings, when people have dementia, are in overdrive. So sometimes water can feel like spikes or needles on the body. So we also need to sometimes turn off the water, wash them up, and then bring water back slowly, not have it continuously going on them. Okay, so here are some reasons why there are bathing issues. One is fear of falling. Let's go back to that brain and that occipital lobe. How are they seeing things? Fear of water. Is it too cold, too hot? Depth perception is off. And this can happen very early. Like right now, I can tell you, I can go like this and see my fingers without really moving my head a lot. As we all age, that comes into about here. A person with dementia, it gets down to about here. So I don't see over here or over here very well. So if I have someone coming from the side or behind me, I may smack out at them because I don't see them until the very last second, and now I'm frightened. It jolts me. So this visual disturbance really is something we need to talk more about. That's why driving is a very sore issue in the beginning of this disease. I tell my families all the time, if your loved one's still driving, I want you to watch for those side view mirrors. If they're ever hanging off or they're taped on, they're hitting them. I just had a gentleman that, unfortunately, they had to take his license away. He was only 57 years old, but he kept popping the front tire on his truck because he missed that curb. Or he didn't miss it, he hit it. And it caused that to happen. Unfamiliar caregivers, disruption in daily routine, and we're going to talk a little bit more about that. Feeling rushed. Let's go. We got somewhere to go. Humiliation of being told to take a bath. Who do we tell to take a bath? A child. Lack of privacy and dignity. And we'll get more into this, but we see that wonderful little 20 there. I'm going to ask you all right now to close your eyes. And I'm going to ask you to count to 20. When you're done counting, open your eyes and just put your hand up a little bit. Ready? Go. Okay, so, well, stop. When that went off, that was 20 seconds. How many of you had your eyes open and hand up before that alarm went off? Right. So when I say to you, someone with dementia needs at least, some of the research is telling us at least 60 seconds. 60. That was only 20. To take information in. Whoop. Take information in, process that information, come up with a response, and give you that response. 60 seconds. Slow down. Because what happens when I ask an open-ended question? What would you like for breakfast? I'm sure if I asked this room, we could come up with 10 or 15 different things. A person with dementia, sometimes when they get an open-ended question, their brain freezes, and they can't come up with any of it. But what do we do as humans? We don't like silence too much. So we come up with another question. So slow down. This first one, habits of a lifetime. What are your habits of a lifetime? When do you take a shower and bath? When do you go to bed? What do you wear to bed? So I'm going to tell you about Chief. Chief was a gentleman I had in my community. He was 6'2". He was 94 years old, one of the most handsome men I'd ever met. And I was a brand new kid out of college, and I went to work, and they were like, we call him Chief because he was the chief of police. I said, okay. And Chief was he was pleasantly confused. He was a great guy. If you got on the conversation about being a police officer, he could talk to you for days. And then one morning I came into work and I had a letter from my staff going, Chief hit us last night. What? That's so out of character for him. So we did what Stephanie talked about in the last session, right? We checked his blood, we did all the medical stuff, everything came back negative. So I came in one night, and I walked in, and I thought maybe taking his clothes off was a problem. That was not the issue. He went nude was not the issue. And they went to put a Johnny on him, and he starts swinging. And I looked at him, and I said, Chief. And I startled him because he was swinging. He goes, what? I said, why are you hitting the staff? And he goes, why are they making me wear a dress? I said, there you go. This man was a Marine, then he was a police officer, and then he was the police chief of New London, Connecticut. He was not wearing a dress. Habits of a lifetime. Who are they? who makes them who they are or what they do. Knowing those little things can make us or break us. We always want to promote independence by helping the person. So if I'm giving someone a bath or shower, I'm handing them a washcloth. They may not wash as well as they need to, but I want them to be part of the process. Again, breaking down step-by-step instructions, directions, inform the person what we're going to do. Stay calm, and look, there it is again. Don't rush, slow down. Their world is much slower than ours. So, how to succeed, right? We want to find the right routine. I look at my father, whenever I see this slide, I always think of my dad. My dad grew up on a farm. He took his bath on Saturday night because he went to church Sunday morning. Then he went into the Navy at 17 years old. He was signed up to take a shower at 7 o'clock at night. After 20 years of being in the submarine service, he came home. He had 2 preteen boys and a brand new baby girl. He still took a shower after dinner at night, and after he took his shower, he put on his pajamas and went in and watched evening, probably the Red Sox or the Yukon Huskies. Now my dad goes into a nursing home, and let's say they're like, oh, Mr. Borden, you're gonna have a shower Tuesdays and Thursdays at 9:30 in the morning. Is that going to work? No, right, exactly. We need to find the right routine. These are the questions that nursing homes and assisted living should be asking you if you have to make that decision, or if you have staff coming into your home to help you. You know what, the best time to give a shower for my loved one is 5 o'clock at night or 1 o'clock in the afternoon. If you go too early, they're not awake enough. They're not gotten the cobwebs out of their brain to really be grounded. We want to make the bathroom comfortable. Is it warm enough? Establish that connection before we do anything. Sometimes we're very task-oriented. I gotta get this done, I gotta get this done, I gotta get this done. Before we go to task, make that personal, friendly connection. Good morning, it's Patty O'Brien. And then stop. Ensure privacy. I hate to tell you how many ladies I have showered in their bra and underwear. They won't take them off. But I guarantee you, once it gets wet, it doesn't feel so good. And they'll say, oh, this feels awful. I know, take that off. And it comes right off. But instead of that fight, right, instead of having that fight for 20 minutes, no, you have to take this off, you have to take this off, you have to take this off, it's okay. Be gentle. Remember that skin is probably thinner than it used to be. And be prepared. Make sure you have everything you need in the bathroom. I've had a couple streakers in my career. And that's when you're trying, you forget that towel, you forget that washcloth, or you forget that medicated shampoo. Can you tell that happened to me? Because that's in my brain. And all of a sudden you go to get it and they're out of the bathroom and gone. So brushing teeth, sequencing, planning. We know from that slide way at the beginning, that's an area of the brain that's damaged early. So how do we do it? Well, first we need to set up the person to brush their teeth, provide that simple instructions, and then there's a technique called hand over hand. So instead of hand under hand, you put the toothbrush in their hand, you put your hand on top, and you move it. So they're holding the toothbrush. Has anyone ever watched any Teepa Snow videos? You have, yeah. So Teepa Snow is an occupational therapist. She's an amazing individual. She comes out of the Carolinas, originally from West Virginia, so has that twangy accent. And she does great videos. And she talks a lot about the hand-over-hand technique. And their videos are free on YouTube, and they're maybe 15 minutes long or less. Really great stuff. Monitor for any swallowing difficulties. As people progress in this disease, swallowing can become a problem. Are they coughing? Are they clearing their throat a lot when we brush teeth? As we move into advanced dementia, sometimes we need to use a toothette and not the toothbrush because it doesn't give as much. If the teeth and jaw clamp down, wait. Because if we go to pull, they usually clamp a little bit harder. And then once they relax, again, step back. Take that breath. Hair washing, again, one of the toughest things I hear a lot from my families. Boy, I even try to get near her head, and it is a fight. It's a fight. So washing the person's hair for them in the sink sometimes can make them feel more comfortable. Some people use dry shampoos. There's other durable medical equipment, the shower chair, inflatable hair washing trays. Another option is going to the barbershop or the hair salon. Your folks usually are not running marathons every day, so they don't need to wash their hair every day. In fact, it's not good to have their hair washed every day. So think about that when, like, how many times do I really need to have the hair washed? Getting dressed. Physical illness or stiffness. We know the part of our brain, right? There was that movement center. Ataxia and apraxia, that motor planning, that's part of this disease. So putting on clothes can become very difficult. Impaired vision, change in fine and gross motor skills, those little touchies. Inability to choose clothing, difficulty putting clothing on correctly, and then refusing to change clothes. Do you ever think they don't want to change their clothes because I'm already in them? And that's a lot of work for me. So here's some successful. Limit the choices. Instead of having a whole bunch of outfits to wear, have one or two or three. This second line, I was doing a program one night, and the next line I said it out loud, and there was an older woman in the backseat, and she just starts bawling. And I was like, good Lord, what did I say? Allow ample time. If getting dressed used to take your loved one 10 minutes, add 20 at least. It's going to take that much longer. So if you need to be the doctor's at 9, you need to start dressing at 8:15. You need to give them that time to get dressed in the morning. So I went to her afterwards and I said, what brought on your tears? She's like, I'm doing everything wrong. Everything wrong. I rush him all the time. I'm like, we have a doctor's appointment. We got to do this. We got to do this. I said, well, now you know. So next time, stop. Take that breath and give him the time. Buy clothing that's easy to put on and take off. I had a gentleman move into my assisted living, and the family read in a book that you change nothing. You want everything to be the same. So he was a circuit court judge in the state of New York. He walked in with suspenders on. He walked in with pants that not only buckled but clipped and zipped. He walked in with handcuffs. I mean, not handcuffs, little cuffs on his, that's not, as a judge, that's not good. Cuffs, and he walked like this. Defeated. Because when he went into the bathroom, he was a full assist. I had to have a staff member go in there with him because they had to take off the jacket. They had to take off the suspenders. They had to undo all this apparatus of the pants. So I said to the daughter, I said, did your father go to the club? And she goes, of course my father went to the club. I said, what day? Well, the judges went on Wednesday, I learned. I said, great, does he have the polo shirt with the, the crest? She goes, oh yeah, we probably have hundreds of those. I said, great, bring those in for me, please. I said, and bring me in golf pants that have a stretch waist. So he changed what he was wearing. He wore shoes. This is how he now was walking. He was independent in the bathroom. He thought every day was Wednesday. He thought every day was golf day. He was going to the club. But he was independent, where before he was a total assist. When you're helping someone get dressed, you want to lay out the clothes in the order they're getting dressed. If someone wants a blue shirt, they have a blue shirt they love, 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 buy them 5. It's okay. If the person resists changing, keep clean underwear and clothing in the bathroom, so when on the toilet and half dressed, you can change out clothes right there. It's just having these little tricks, right? Stephanie talked about your toolbox. This is a great thing to have in your toolbox. In the bathroom, have that extra pair of underwear, have that extra clothing. Be flexible and patient. Okay, so why are there toileting issues? Person with dementia may forget where the bathroom is. The individual gets easily distracted and may not realize they need to go to the bathroom. Complicated clothing, like I said, may no longer recognize the toilet or use other receptacles. People in the late stages lose control of their bowel and bladder because they don't understand the urge to go into the bathroom. And then medical issues, such as a UTI or a side effect from a medication. So if someone's pretty continent for a long time and then all of a sudden becomes incontinent, call that doctor. Something's going on, maybe. Check it out. But here's some things for successful toileting. Establish a bathroom schedule. Simplify that clothing. Keep a light on in the bathroom to improve visibility. You know, when a door is closed, they might be like, I don't know what's behind that door, so I'm not going through that door. There's that fear. Make sure that clear pathway, pay attention to fluid intake, and good diet for bowels. Here's one of the big ones, color contrast of toilet, floor, and wall. If you think about your bathroom right now, what's the color of your floor? For many of it, it's white. What color is that toilet? It's white. What color is the wall behind the toilet? White. And now I'm trying to get someone to sit on a toilet, and they don't see it because it's white on white on white. And they're thinking, you want me to sit on the floor to go to the bathroom? Who's the crazy one here? You. So guess what? I'm going to fight you. I'm going to push at you. I'm going to give you a hard time because I'm not sitting all the way on the floor to go to the bathroom. That's why this picture of this toilet, red seat, right? That red pops. That's what it's all about. Create visual reminders. Maybe it's a picture of the toilet on the door. And if they move into an assisted living or a nursing home and they still are using the toilet, you want to have the bed face the bathroom if you can, if that's doable. So when they wake up, they see it. Incontinence with dementia. You know, there's lots of different causes of it. Inability to recognize natural urges, forgetting where the bathroom is, not mobile enough to get to the bathroom, and medical issues and medical side effects. Here's the thing with incontinence. Incontinence technically should not come till late stage. But sometimes we make people incontinent earlier because we think they can't do that. And we put those attends on them and then we're in trouble. One of my favorite stories to tell, I had a gentleman, and he lost his ability to speak very early in the disease. He certainly was affected in the temporal lobes. And he was walking down the hallway, and he's tugging at his pants, he's tugging at his pants. And I said, Bob, are you looking for the bathroom? He goes, no, 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 no. And he keeps tugging. So I take him to the bathroom. I open the door. He goes, oh, thank you. Went in and used the bathroom. I said to his wife, what does your husband call the bathroom? And she's like, well, you know, I used to work in upstate New York. She goes, well, you know, we had a beautiful log cabin that we winterized. Before we winterized it, we had an outhouse. I said, great, he calls it the outhouse. She goes, no. I go, what does he call it? He calls it the shit house. I was like, okay. She goes, well, you're not going to say that. I go, we'll see. So the next time I see Bob and he's tugging at his pants, he's tugging at his pants, he's tugging at his pants. And I said, Bob, are you looking for the bathroom? He goes, no, no. And just defeated. His face was just defeated. He goes, no, 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 no. And I said, Bob, are you looking for the shit house? He goes, yes. And took him right into the bathroom. Learning what people call things. We live in the United States of America. We live in a melting pot. And when folks are born in a different country or they grew up in a household where they didn't learn English until later in life, they sometimes go back to that native language. I used to work in Rocky Hill, Connecticut. Majority of my residents spoke Italian. Thank God some of their kids did, and some of my staff did. But I also have lots of folks who went back to Spanish, went back to Polish, Ukrainian. You know, there's lots of different languages out there. And because of here in the United States, we get a lot of that. All right, so some strategies. Consider incontinence products. Determine the person's typical urine and bowel patterns. When we write down when they go and how often, sometimes we see a pattern, and we try to anticipate that. Use the bathroom before bedtime. Establish that toileting schedule. Cover the mirrors in the bathroom. Because sometimes they'll fight with that person. Because why are you looking at me on the toilet? It's very disruptive. Wear clothes, again, that are easily removed. And if incontinence becomes sudden, consider a medical problem, like we said. Why are there eating issues? Maybe I'm not able to ask for food. Maybe I'm not able to recognize my hunger pains. I don't recognize being full. My smell and my taste change. May lack ability to initiate eating. There's that initiation piece again that we talked about. Inability to find or recognize food and drinks. Difficulty opening packages and preparing. Meals. I lack judgment and to know who should be or should not be eaten. Persons with dementia do not remember if they have or have not eaten. A great deal. So here's some strategies. You want to provide meals in a quiet place. Make sure the TV's not on. Make sure the music's not on with words. Because if I'm having trouble concentrating, I might start singing the words to a song instead of concentrating on eating. Conversation might be difficult during a meal because I really need to concentrate. Don't rush mealtime. There it is again. Slow down. Use simple place settings. Finger foods might make it easier. Provide meals on a routine schedule. Sit down beside them, or even better, across from them, so they can mirror you. Exercise may increase the appetite. Have snacks and drinks visible, and offer them often. Person may need their food cut up. Do this before the food comes out. If the person is pocketing food or coughs on thin liquids, let your physician know. A swallowing of valve may need to be done. If a person eats very little, boost nutrition with increased calories. So here are some creative ideas that we've done. Over here on the left, you'll see on the top, that's an ice cream cone with mac and cheese in it. On the bottom is a hot dog bun with food in it. So learn what their favorite foods are. Place food on a colored plate. Here's that colors again. Right? We talked about the toilet, the white on the white on the white. Think about the white tablecloth with the white plate, with maybe some mashed potatoes and turkey on it. And they have a nice social grace about them and say, I'm not hungry, but maybe they don't see it. Decrease distractions, and sometimes we need to add sugar and sweet toppings. Sugar and sweet is the last taste bud that goes on the tongue. So to get people to eat, sometimes we need to increase that flavor. I had a woman, if she didn't eat, in about an hour after lunch, she kind of dropped to the floor because she was an insulin-dependent diabetic. If she didn't eat, her blood sugars bottomed right out. So we would actually pour, it might make you go, bleh, pour sweet and low all over her meals. And she would eat them then because she could taste them. But as we move into the later stages, people are at risk for choking and aspiration. They may forget to swallow. Food does become pocketed. Thin liquids are the most difficult to swallow. Cold drinks are easier to swallow than hot drinks. And then they are high risk for dehydration. We need to offer fluids continuously. So important. Your mother ever tell you, don't talk when you're eating, right? Because there's two tubes, one to the stomach, one to the lungs. When we're talking, those vocal cords shut off that tube to the lungs so nothing gets in those wonderful lungs. If those have started to slow down because of dementia, water, thin liquids still are quick. And they can get down and then get into those lungs. Once anything foreign hits those lungs, bacteria can start to grow. And one of the hardest things is sometimes people silently aspirate. So we don't even know that that's happening until they have a full-blown pneumonia. So some interventions frequently remind the person to swallow, gently brush the cheek or the neck. Food can be ground or pureed. Thin liquids are the most difficult to swallow. Sometimes they will have you thicken them. Cold drinks, again, are easier to swallow than hot. We want to offer those fluids. Feed in an upright position. Keep in that position for 30 minutes after eating, because if we lay back down, food comes up. And then give small amounts of food at one time. Have you ever gotten a big plate of food and going, oh my God, I don't even know where to start? That happens a lot to the person with dementia. They look at it and go, I don't know where to start, so I'm just not even going to start. I'm not going to start. I'm just going to look at it and maybe push it away, back up, do whatever I need to do. What to do if nothing works? Because there'll be times, right? Penny, I tried this, I slowed down, I had everything ready for the shower, all these different things. Try not to get frustrated. Take a deep breath. Remember, the person with dementia can't help it. Connect with each other professionally. Connect with other professionals. Seek guidance, input, and support. This is hard work. And remember, you have a strong team. I just went to the New England Professional Conference a couple weeks ago. And there was a young woman that talked about the 3 teams that you need. One is your medical team. Those are your doctors, right? You need those docs. The next is your disease team. So that's your Alzheimer's Association, or maybe it's the Lewy Body Association, or maybe it's a frontal temporal lobe association. And then it's your team, your friends, your neighbors, whoever can help you. This isn't a one-doctor disease. It's not a one-team disease. It's who do I gather around me? And there was another speaker I heard many, many years ago, and this is what she said. Don't let anybody should on you. At first I said, what did she say? Don't let anybody should on you. And we waited. And she goes, you know, when they go, you should have done this, and you should have done that, and you shouldn't have done that. Because in that moment, you're doing the best you can. And guess what? We'll all make mistakes. And we'll get angry with ourselves. We'll get frustrated with ourselves because we are human. So again, step back. Take a breath. And then try again. Try to learn from your mistakes. I've made them a million times. When I worked in facilities, I said, I'm sorry 20, 30 times a day to my clients because I was always saying something stupid. Like, don't you remember? What? Like, come on. With the last speaker, she also had this up on her slides, but it is so true. The dementia patient is not giving you a hard time. The dementia patient is having a hard time. That comes out of frustration. Again, if I'm looking at my shoes and I'm tying them, and I've always tied them, and I should be able to tie them, I've been tying them since I was probably 4 years old. When my aunt was left-handed, because I'm left-handed, had to teach me. My mother couldn't teach me. She gave up. My Aunt Joan had to teach me. But now I look there and I go to try to do it, and I can't. Of course I'm frustrated. Of course I'm angry. If you're telling me to do something, and I'm not understanding your words, of course I'm frustrated. Of course I'm angry at you. I'm sorry helps. I'm sorry I embarrassed you. I'm sorry if I made you feel like a child. I'm sorry if I made you angry. That was not my intent. Hit that emotional center. When I worked in facilities, I would say to my staff at the end of every day, how did you bring about an emotional response? A positive emotional response. And a lot of times it was easy as, you know, Patty, when I walked into the room, I said, hi, it's Patty. It's good to see you. And then I waited. Instead of walking in and just start going to task. My housekeepers got yelled at the most because they would walk in and go, hi, and they would start cleaning. Now, I'm a person that's just processing that there's a person in my room, and you're touching my stuff? Of course I'm going to yell at you. What? Why are you here? What are you doing? What's going on? That connection, before any of this stuff happens, any of the steps, anything you need to happen, that connection is the most important thing. Think of the brain. Brain cells, right? They need to talk to each other. Now we have a dementia. Something gets between them. Or something's got inside that brain cell, choked it, and this one's sending out information, not picking it up because this one's gone. Slow down. Take a breath. So I am from Hartford Healthcare. I'm from the Center for Healthy Aging. Hartford Healthcare is one of the 2 largest hospital healthcare systems in Connecticut. I want to thank the Rhode Island chapter for inviting me to come today. I did speak last year on the virtual, and she called me. She was like, would you come? So I just want to tell the story. I had to call my vice president of Hartford Healthcare, who I didn't want him to know my name, but I had to talk to Dr. Kumar, and he said, if the COVID number goes over 10, you cannot go. Yesterday in Connecticut it was 9.4. I was like, so thank God for not hitting 10 with COVID, and for Dr. Kumar's, of course, advice and guidance. He's been amazing during this whole time. But thank you for what you do. I don't think that anybody signs up for this. I know as an adult child who's taking care of a mom, I call myself a weekend warrior. I have other caregivers during the week, but from Friday to Sunday, I'm with my mom every weekend. And there's some weekends I would like to be going to that party. But that's okay. She was an amazing mom, so every day's a blessing. Thanks, everybody.
Right.
Can you all tell I just started wearing glasses? I'm like, on, off, on, off, on, off.
Just want to say thank you so much for attending the caregiver track today. I'm sure you have learned a lot of helpful information and have access to a lot of resources as well. As we close out the conference this afternoon, we are offering a meditation session, which is going to be really special in the Plaza Ballroom. So that's right out these grand ballroom doors, over to the left. Keep on going. You'll see the signs for the Plaza Ballroom, and that's how we'll be ending the conference today. Again, thank you for attending, and I hope that it was a wonderful time for you. Thank you.